Welcome to Podcast UK. In today's episode, we're looking at carpal tunnel syndrome.
Hello, and welcome to this episode from Podcast UK. My name is Matt Stone. I'm a specialty registrar from Yorkshire, and today I'm joined by Mr. Sanjib Majumder, a consultant plastic surgeon and hand surgeon from the Mid-Yorkshire Teaching Hospitals NHS Trust. Many UK listeners will also know him as the National Online Learning Programme Director for Plastic Surgery. Now, in today's episode, we're going to be talking about carpal tunnel syndrome. Obviously, this is a big topic to compress into a single session, so there'll be a further episode in the coming weeks which focuses more on the finer details of the surgical management. So, Mr. Majumder, how much of a problem is carpal tunnel syndrome, and why does this topic deserve an entire podcast?
Yeah, Matt, carpal tunnel syndrome is very common. It affects a very large number of people. It is the most common elective hand surgery condition there is. And whilst it's not a life-threatening condition, it certainly does affect the quality of life significantly. And this is not only because they can't use their hands normally at work or at home, but also it affects people's sleep, which can become attritional to one's mental health. But carpal tunnel syndrome is one of those conditions that everybody thinks they know everything about because it's, so, as I said, so common and we deal with it all the time. But it's not quite as straightforward as people think. It's got so much dogma associated with it. And hopefully at the end of this podcast, we would have clarified some of those things.
Yes, I read a statistic where approximately 10% of people can suffer from carpal tunnel syndrome at some point in their life. Could you tell us a little bit more, please, about the epidemiology of carpal tunnel syndrome?
So yes, the epidemiology, the vast majority of people who get carpal tunnel syndrome, we don't know why they get it. There's a small percentage of people who have acromegaly or hypothyroidism or rheumatoid arthritis. Diabetes is also associated with increased risk of carpal tunnel syndrome, and certainly pregnancy as well. But the vast majority are idiopathic. Women are supposed to be more prone to it than men, people in their middle age, whatever middle age is. And it doesn't seem to be limited to the dominant hand or more the dominant hand than a non-dominant hand. And of course, there's this whole discussion about work-related upper limb disorders or repeated stress. Is using the computer keyboard over and over or using vibration tools. Do these things cause carpal tunnel syndrome? The jury's out on that, so we can't go and say definitively that any of these things are causative per se.
And you said that in the vast majority of people with carpal tunnel syndrome, the cause is idiopathic. But are there any aspects in the anatomy of the carpal tunnel that are pertinent to our understanding of carpal tunnel syndrome?
As I tell all my trainees who, we are plastic surgeons, we want to be reconstructive surgeons, the first thing to do is to deconstruct everything back to the anatomy, the physiology, the pathoanatomy and the pathophysiology. So the anatomy of the carpal tunnel, I'm not going to spend too much time on, but obviously the carpal tunnel is that tunnel formed by the carpal bones on the dorsal aspect and the flexor retinaculum sitting across the carpal bones. The important thing about the anatomy and thus the pathoanatomy of carpal tunnel syndrome is that this tunnel formed by the bones and the flexor retinaculum is unyielding, meaning the volume of the carpal tunnel doesn't have the ability to expand because there's no real give in the tissues, which obviously means that the structures within the carpal tunnel are vulnerable to being compressed. So not a dissimilar situation to the structures within the fascial compartments of the limbs. Now, within the carpal tunnel are housed the flexor tendons to the digits and the median nerve. Now, compressing the flexor tendons makes no particular difference, but compressing the median nerve can lead to the symptoms and signs of carpal tunnel syndrome, which sort of segues us into the pathophysiology.
That brings us nicely on to our next question, which is, what are the theories that explain the symptoms of carpal tunnel syndrome?
As with so many things in plastic surgery, blood supply is the issue here. Now, initially, when there's compression, the median nerve itself, as in the axons, perhaps not suffering from direct compression, but it's more of the compression of the vasa nervosa, which is the very thin wall vessels which run on the outside of the median nerve, and as such very vulnerable to compression, leading to ischemia of the median nerve, essentially a neuropraxia sort of situation. Now we know that nerves don't like ischemia, and the way nerves respond to ischemia is by stopping working, so thus you get numbness, paresthesia, and all the other symptoms and signs associated with a nerve that's not working. Over time, however, if the nerve is being compressed fairly regularly or continuously, then you will start to see actual macroscopic changes and flattening of the median nerve. And we'll discuss this with a little bit more detail when we're talking about the use of ultrasound in diagnosing carpal tunnel syndrome. However, important to remember, at least in the very beginning, it's ischemia that's the problem.
What are the main symptoms when you see these patients that helps to guide the diagnosis?
Yes, so the symptoms are pretty well known. People complain of numbness, they complain of paresthesia, pins and needles, classically affecting the radial 3.5 digits, which is the median nerve distribution. But patients not infrequently say, my whole hand becomes numb when I've got the problem. People complain of dropping things, clumsiness, pain, which can be limited to the hand or sometimes even extend proximally all the way up to the shoulder. Difficult to explain why. Certainly it is something that is a symptom. It can be bilateral, and as I said before, the dominant hand may not be the one that is worse off. It could be at different stages, the two hands in terms of symptomology. The symptoms may be intermittent or they may be permanent. There are things that precipitate symptoms, and patients will say when they are using cutlery or using their mobile phone, using their tablet, newspapers for people who still read newspapers, driving, using tools. So why do patients get symptoms when they're carrying out these tasks? The common thing in all of these tasks is actually gripping. Now, when people grip, the muscles in the forearm contract, the flexor muscles, causing the flexor tendons to be pulled in more proximally. Now, the FDP tendons have the lumbricals that come off them, and this happens just distal to the distal end of the carpal tunnel. When you flex your fingers, those lumbrical muscles are brought into the carpal tunnel and crowd the carpal tunnel. So you essentially cause an increase of the volume of the contents within the carpal tunnel. The carpal tunnel itself cannot expand because it's unyielding, as we discussed, and this causes compression of the median nerve.
The other thing you hear a lot is that people get symptoms at nighttime when in bed, where they get pain or numbness that either wakes them up or that's there when they wake up in the morning. What causes that?
Now, there are a couple of reasons for that. One is when people go to bed, many people lay down and they flex at the wrist. Now, essentially, that's like a Phalen's test. And it's been shown that when you flex at the wrist, the volume of the carpal tunnel decreases. They've done MRI studies to confirm this. So essentially now you have decrease in the volume of the carpal tunnel itself. And if you have a hand which is prone to median nerve compression in the carpal tunnel, obviously this may be precipitated. This can be helped by using splints, but there are people who will have splints at night and say we still get problems even though the splints are preventing us from flexing. So there must be some other factor that's causing this. And it's redistribution of fluid. Now I'll take you back to paroxysmal nocturnal dyspnea, where a lot of people who have issues with heart failure tend to have worsening of heart failure at night. And this is because when they lay down, you have the redistribution of the fluid which is hanging around your legs during when you're standing up and walking around, and then you get flat in your bed. This redistribution of fluid goes into your heart and can overload your heart. So similarly, the redistribution of fluid can go into your hands as well, and you have essentially got increased volume of contents within the unyielding carpal tunnel. This increase in volume of contents is also responsible for carpal tunnel syndrome in people who are acromegalic, people with hypothyroidism, rheumatoid arthritis, and pregnancy. Does that make sense? Now, while we're pretty sure that this is what's happening, what we don't know is what tips over the 90+% of people who have idiopathic carpal tunnel syndrome into being vulnerable for nerve compression in the carpal tunnel. So not unlike astronomers and the Big Bang Theory, they're pretty sure they know what has happened since the Big Bang, but they don't know what precipitated the Big Bang. Why did it actually happen? Now, just to finish off the symptoms, patients will often tell you that when they wake up at night with this numbness or discomfort or pain in their hand, they will often hang their hands down in an effort to try to improve their symptoms, or they might do what is known as a flick test, which is flicking their wrists back and forth, because many patients think, well, they're trying to improve the blood supply to their hand because that's the reason they're getting the symptom. They're, as we discussed, not far off the truth, but not necessarily macroscopic blood supply. That's the issue here. I mean, I personally think in the vast majority of cases, the history where the symptoms are outlined is quite accurate in getting a diagnosis.
And when it comes to examining the patient, what is your approach?
Often there's nothing on the general examination of the hand, especially early on in carpal tunnel syndrome. With time, people can have flattening of the thenar eminence as you have wasting of the abductor to the thumb, the abductor pollicis brevis. You can have weak thumb abduction, which is moving the thumb at 90 degrees to the plane of the palm. You can have altered sensibility in the radial 3.5 digits. It's important to assess for sensibility in the distribution of the palmar cutaneous nerve, which is just down the center of the palm, the proximal 1/3. And the reason for that is if the median nerve is being compressed more proximally, say in the forearm, that area will be numb. But if the median nerve is being compressed in the carpal tunnel, that area will not be numb because the palmar cutaneous nerve, as you know, comes off more proximally, about 5 centimeter proximal to the wrist crease itself. But as I said, often there is very little to find. It's quite important at this point to state that the examination of the entire upper limb as well as the neck is quite important, because one needs to rule out other things that can be causing the same symptoms. Remember, the nerves come from the neck and they can be compressed in the neck or anywhere in the passage from the neck all the way up to the hand. So don't just dive in, think, I'm just going to only examine the hand. You've got to examine the neck and the whole upper limb. I cannot stress this enough.
And what about provocative tests such as Tinel's, Phelan's, and many others?
Now, this is where the dogma and what's actually true or not true comes into play. Every medical student knows about Tinel's test. Tinel's test described by Jules Tinel wasn't described for the diagnosis of carpal tunnel syndrome. It was developed by Jules Tinel to track the recovery of injured nerves, and it's great for that, if someone's had a nerve injury, see how things are progressing. But in terms of carpal tunnel syndrome, look, it's at best 75% sensitive, more between 50 and 75% sensitive, and not particularly any better in terms of specificity. Phelan's is another one that is done where you flex the hand down at the wrist and wait between 30 to 60 seconds. Not particularly different in terms of sensitivity or specificity than Tinel's, really. Durkan's, which is essentially compression of the carpal tunnel, is a lot more sensitive, up to 81% sensitive and a bit more specific. But if you do Phelan's and Durkan's together, so essentially flexing at the wrist as well as compressing the carpal tunnel, which is called PH Durkan's, which is Phelan's and Durkan's together, the sensitivity then jumps to between 80 to 90%. So significantly more accurate. The other thing is hand elevation, which a lot more people are using now. Hand elevation test is also very sensitive. It's above 80%. So they're all of these provocative tests, and it's important to know the sensitivity of these tests and the specificity to then decide on how reliable it is. So in plain English, if one uses Tinel's or Phelan's by itself, up to half the patient with carpal tunnel syndrome may be misdiagnosed as not having carpal tunnel syndrome.
What role do investigations play in the diagnosis? Should all patients have nerve conduction studies?
So whilst the combination of history, examination, including provocative tests, will catch the vast majority of people with carpal tunnel syndrome, you'll have a group of people in whom the diagnosis is still not clear. The use of electrodiagnostic tests such as nerve conduction studies and EMGs can certainly contribute, but perhaps not as much as people think. The sensitivity of nerve conduction studies and EMGs vary between 50 to 94% depending on which paper you read. The specificity not dissimilar. So again, the results must be taken in collaboration with the history, the examination, including the provocative tests.
That's very interesting, given that nerve conduction studies are very much part of the diagnosis pathways often used by GPs and sometimes required by funding bodies. But what about ultrasound? I've been told that ultrasound's the new gold standard. Is that true?
The short answer is no. I mean, at least not yet. There is a lot of work going into it, and as ultrasound technology improves, certainly the diagnostic rate is improving. Ultrasonographers have looked at the flattening ratio of the median nerve, the median nerve to ulnar nerve ratio, but the most accurate indicator is supposed to be the cross-sectional area of the median nerve at the inlet of the tunnel. But what about the all-important sensitivity and specificity of this investigation? Well, it varies from about 60% sensitive to some papers quote 94% sensitive, and specificity very similar. There are also differences demographically, population specific. So they have looked at patients with a European background versus patients with an Asian background. And obviously there may be differences with gender as well, and the general size of the patient, because what they're looking at is the cross-section of the median nerve and how it compares with what is considered normal. And this normal may vary depending on all the factors we just discussed.
Yeah, so obviously the diagnosis of carpal tunnel syndrome is not always quite as straightforward as we sometimes think. Any tips?
You've got to take the history, examination including the neck and the whole of the upper limb, provocative tests. You can use nerve conduction studies and EMGs if necessary, ultrasound if available and necessary. Package them together and come to a diagnosis, keeping in mind that notwithstanding carpal tunnel syndrome being the most common reason for the symptoms we've discussed, the other things then can cause this.
What are the differential diagnoses?
Now, in the diabetic, you can have peripheral neuropathy, which can cause very similar symptoms or actually coexist. You can have compression, as we discussed, proximally in the neck, all the way up to the carpal tunnel, including the forearm, where you can have Lassiter's syndrome. You can also have double crush, where you can have carpal tunnel as well as nerve compression more proximally. Of course, one must not forget to find out if there's been any neck injuries in the past, including whiplash injuries. So all of these things are quite important to factor in before coming to the correct diagnosis and thus the correct treatment.
So once you've diagnosed carpal tunnel syndrome, how do you decide upon your management plan?
In terms of treatment, the way I treat patients with carpal tunnel syndrome is the same way I treat any other patient, which is to outline the different modalities of treatment available, and then they decide. Non-invasive options include using splints, which are essentially like a Futuro splint, to prevent flexion at the wrist. And this can help people when their main complaint may be that they're not getting a good night's sleep. I personally had carpal tunnel syndrome, and I could really not get on with my splints. I found it very uncomfortable, so I stopped using them. But many people love their splints, and they're quite happy not to go on to anything more invasive. Steroid injections certainly have a role in the management of carpal tunnel syndrome. You inject steroids, whether it's hydrocortisone or Adcortil, into the carpal tunnel itself, ideally under ultrasound guidance so that you don't end up injuring the median nerve, because otherwise it's a blind procedure. And usually about 10 milligrams of something like triamcinolone is injected into the carpal tunnel. The use of steroids for carpal tunnel syndrome is not curative and at best will give you temporary relief, and that may vary between a month up to 6 months. I think they're quite useful for patients who are pregnant and have carpal tunnel syndrome, because often once they've had the baby, the carpal tunnel syndrome would disappear. And in these patients, the carpal tunnel syndrome is a temporary affliction, and you don't really want to go on and do an operation on a patient who's pregnant if you can help it. So it's a nice compromise, really. The other instance where I find the use of steroid injections quite useful is when the diagnosis is not clear, notwithstanding the history, the examinations and the investigations. The steroid injections may not only be therapeutic, but it may be diagnostic, in as much as if the steroid injection into the carpal tunnel helps, then it's pretty clear that the problem is nerve compression within the carpal tunnel.
And considering surgery, what are the different options and advantages and disadvantages of each of these?
The only thing that will give you permanent relief from carpal tunnel syndrome symptoms is an operation, and the operation could be the classical open carpal tunnel decompression, which is most commonly done, or you can approach the decompression of the carpal tunnel endoscopically, which is a closed technique where the flexor retinaculum is released with the use of an endoscopic device.
And which of these techniques do you think is superior?
Which technique is better? Well, they're proponents of both. The people who prefer to use the open technique say, well, there's less chance of incomplete release of the flexor retinaculum, less chance of injuring the median nerve or the superficial palmar arch. Proponents of the endoscopic technique will say the endoscopes themselves have improved in design, so you get a much better visualization, and certainly it's a much smaller cut, so patients can return to work and normal activities much more quickly. To some extent, there's an element of personal preference from the surgeons themselves. We're going to do an entire podcast on how to do a carpal tunnel decompression, and we'll go into greater detail about markings and incisions, etc.
What do you advise patients preoperatively about their chances of getting better after carpal tunnel surgery? Can you tell which patients are going to improve and which won't?
I tell my patients very clearly that I cannot predict how much, if any, improvement they might have in their symptomology from the release of a carpal tunnel. That's a carpal tunnel decompression. And the reason for that is it is quite difficult, I think impossible, to tell beforehand, even with nerve conduction studies, how much irreversible damage to the median nerve may be present. So if someone has carpal tunnel syndrome but has reversible injury to the median nerve, then they should be expecting a full recovery or significant recovery. And the vast majority of patients really fall into this category. But you'll have a group of patients who have had carpal tunnel syndrome for a long time, or the compression has been quite severe, and they may have irreversible injury to either the entire median nerve or part of the median nerve, in which case they will either have no recovery or partial recovery from the symptoms.
What about the intraoperative findings? Can you tell from the appearance of the median nerve during the operation how much recovery they might expect?
Quite interestingly, even intraoperative findings don't seem to correlate with prognosis very well. I've had patients who've had very squash-looking, erythematous-looking nerves, and they recover very well, whilst others have very normal looking nerves and they don't do that well. So I think one has to be honest with the patients and say, look, we cannot predict how much improvement you might get from the operation, if any improvement at all.
What about in that difficult situation where someone has a carpal tunnel decompression, but they just don't get any improvement? Do they just have to accept that the damage is long-standing and there's nothing else that can be done?
You've got to sit down and work out why they may not have had improvement. One could be irreversible median nerve damage, as we discussed. Second, has the carpal tunnel being adequately decompressed? That's the second thing. Thirdly, is the diagnosis correct? Do they have compression elsewhere, as we have discussed, either as the main area of compression or in addition to having carpal tunnel syndrome as well, the so-called double crush syndrome. And of course, patients who are diabetic may have an element of peripheral neuropathy, which may contribute to their symptoms as well as the median nerve compression.
Finally, Mr. Majumder, is it possible to get recurrence of carpal tunnel syndrome?
I've got to say that I have seen patients who have had a carpal tunnel decompression many years ago, and they can have a recurrence of the carpal tunnel syndrome, in which case a redo carpal tunnel decompression may be helpful. But before one rushes in with a knife, I think these patients need to be investigated properly and be counseled properly as to the prognosis after an operation, which is more unpredictable than for people who are having primary carpal tunnel decompression.
Fantastic. Well, it just remains me to say thank you to you, Mr. Majumder, and thank you to everyone for listening. I hope you found that useful. Goodbye. Podplast UK is a collaboration between UK plastic surgery trainees and consultants. The content reflects individuals' practice, and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.